Good afternoon, everyone. My name is Denise Mananis. I am the Assistant Vice President for External Affairs for St. John's Riverside Hospital, and I'd like to welcome you all to today's presentation on post-op pain in the neck. What are my options? Before we get going, though, I would like to thank my team, producer for today's webinar, Jason Latore, our media production manager, Nancy Anabi, who is our community liaison, who helps find and set all of these programs up, and Candace Cousins-Hopkins, our Associate Director of External Affairs. They are a great team and they do wonderful work, and so I thank them all. Also, I would like to speak a little bit about our partners. We have Sally Pinto from the Yonkers Neighborhood Naturally Occurring Retirement Community, which is under the umbrella of the Yonkers Office for the Aging and the Westchester Jewish Community Services, and Z. Baird, who is from the Yonkers Public Library, which has 3 locations, the Riverfront, the Will, and Crestwood Library. And today's speaker, I would like to give you a little bit of background about. Dr. Simon Morr has quite a pedigree. And so let me tell you a little bit about him. He is a neurosurgeon who is dual trained in neurosurgical and orthopedic spine surgery. He provides comprehensive microscopic neurosurgical and reconstructive orthopedic spinal care with a special focus on advanced degeneration, tumors, infections, traumatic fractures, and complex deformities, including kyphosis and scoliosis. He has a keen interest in conditions of the craniocervical junction and the base of the skull. He also cares for patients with a variety of brain conditions, including tumors and trauma. After completing his tenure as chief resident of the neurosurgery service, he was invited to stay on as assistant professor of neurosurgery at the University of Buffalo, where he focused on spine surgery, brain trauma, and brain tumors. Dr. Morr started his own practice at the beginning of 2022 so as to broaden his institutional availability, both city and nationwide. With the creation of this new flexible and nimble platform, our new practice aims to provide all patients, or his new practice aims to provide all patients the most convenient, streamlined, and personalized experience. He favors minimally invasive and conservative approaches whenever possible, but often sees patients who have had previous surgery and require extensive revision and reconstruction, hence the topic that we're going to address today. He is trained and comfortable with advanced new robotic and navigated techniques, as well as radiosurgery, when the best option is knifeless surgery. So Dr. Morr, thank you so much. I know that you had some emergency surgery, so we have you right outside an OR ready to address our audience, and so we appreciate your time always. So to begin, I'd like to start with our first question. In our community, and this speaks to what we just said in your biography, there are definitely 2 kinds of patients. One that has been to a neurosurgeon, one who has had surgery, and one who has not. So when you are addressing these patients for the first time in your office, I mean, how do you address each of these groups differently?
Good afternoon. Thank you for having me. The most important thing for both patients, I think, whether you're addressing the new patient that has never ever seen a surgeon before, or someone who's been to many surgeons or has even had many surgeries, is first and foremost to make them feel comfortable, and most importantly, make them feel informed. And so when someone comes in and sees me, we sit down, we go through their entire history, how it all started, and we go through their imaging. And I like to kind of turn the computer around, and I want to walk my patient through their own imaging. They need to understand what it is that they have and what the real options are. I think we need to avoid scaring people, but we also need to avoid under-informing people about the possibilities and also what could happen, what the options are. That's why I think on average, a patient visit with me is 40 minutes, an hour, so not unheard of to be longer. Most people have a lot of questions, most people get nervous, and there's always another phone appointment so we could revisit everything. And a lot of these questions are, do I really need something? And need is a strong word. It has to be real informed. Do you, we have to inform what happens if you don't do anything, what happens natural history, and what the options are if you do decide to do something, from the smallest to the biggest. I think there's a lot of fear, and we need to address those fears. And when it comes to patients who have had previous surgery, very often the questions are, what was done before? Why was this done? And I think very often I spend a lot of time going through their previous surgeries and explaining that to them, and then also what the next steps are as well.
Very interesting. So would you say in your practice that you're seeing a lot of both types of patients, or are you seeing more of the people who now have already had surgeries, maybe didn't get the results that they were interested in, and now you're working out plans to help them move forward and maybe correct or enhance things that were done in the past?
So I think I'm seeing both, actually, but a very unique kind of both. For the patients that have never had surgery before, I'm often seeing patients that have had difficulty finding an answer, finding a diagnosis. Why? I'm almost never seeing people who've never ever seen a surgeon before, and just happens to be my referral pattern. Kind of people are sending me the difficult cases. And things can be difficult from a diagnostic perspective, and diagnosis is obviously the art of finding out what is wrong rather than the art of treating anything. I think the first step is diagnosis. So people have questions, people have concerns. The first step is to find out what is going on. So I'll see both people who've had previous surgery and maybe they've been told they don't know what's happening now. They don't know why surgeries failed. They don't know why it initially succeeded and now it's worse again. Or I see patients that say, I've been to 10 doctors and nobody's been able to figure out what's been going on. And it's often, surgeons, orthopedic surgeons, neurosurgeons, radiologists, neurologists, and it just, nobody seems to know. So very often it's just very close attention, working through possibilities systematically. And that's where really I think we can help.
Very interesting. So stepping back though, because you see a lot of people who've had a lot of experience seeing doctors already, having an issue, but for someone out in the community who may just be experiencing, have back pain, that seems like a symptom everybody has as they age, and neck pain. Oh, I twisted, I slept funny. What are the things that should tell people that now it's time to actually bring this up to my primary, or I should be questioning whether or not I should be seeing somebody like a neurosurgeon to address these things? What's the tip-off?
The answer to that question is going to have to depend on a patient-to-patient basis, but fundamentally, I think we need to divide function and pain. From a function perspective, you want to address always a loss in dexterity, hand function, clumsiness, balance issues. You want to address weakness, and you want to address numbness. You also want to address pain that's radiating, but really you want to point towards a functional issue, balance issues, clumsiness, writing difficulty, just doing things you were able to do before. People often say it's aging. Aging is a complex of things happening, but if you are losing function, you at least want to know what's going on. So that's from a function level. But to your point about pain, so again, function always should be investigated, because whether it's spine or brain, or maybe it's just something really simple like a carpal tunnel, right? Something in the hand. Maybe it's just hand arthritis. That may be, but it's worth investigating. From a pain perspective, I would say, in my opinion, there's two criteria. Pain is a very subjective thing. Number one, pain is never an emergency. Functional loss can be an emergency, but pain is never an emergency. But you should probably talk to your primary or talk to a specialist, and you can call us and get a phone appointment just to talk to someone. No pictures to look at, that's okay. We can get a phone appointment. You probably won't there's nothing to talk about for 40 minutes with a subspecialty surgeon, but you can call the office and we'll direct you to the right person. Nobody should feel hesitant. But from a pain perspective, I would use two criteria. Number one, is it stopping you from doing things you like doing or have been doing or are used to doing? Number two, do you think about it more than you don't think about it? Basically, do you spend more than half your waking day thinking about it? Does it interfere with more than half of your life that you would otherwise spend doing other things?
Very
I would say if those are the criteria where I would say worth checking out.
What are some of the reasons why a patient would continue to have pain or after they've already had back or neck surgery to correct a situation?
We've learned many new things about the spine. And so let's say they've had a surgery. And a lot of the things we've learned have to do with alignment. A lot of the things we've learned have to do with looking at imaging much more closely and also localizing the patient's symptoms to particular levels much more closely. We have extensive anatomic studies. Patients are often surprised by just the amount of tests I have them do in the office in terms of strength testing, balance testing, sensation testing, all sorts of pieces of equipment. That's from a symptom perspective. Very often that gives us a lot of information. From a radiographic perspective, we have fairly new, fresh techniques of understanding and diagnosing issues, including the angles of the spine. And these are all things that can contribute to pain and to persistent weakness or dysfunction.
Even post-surgery, right?
Even post-surgery, because I'll be honest, a lot of surgeries don't address all these issues, and historically standard of care surgeries don't always address these issues, but frankly, not everyone is looking for these things. So we have information on how to diagnose and how to assess the spine that's only 10, 15 years old, but is completely transformative and can change how we look at things. So one of the things that people often say is they come see me and I'm getting scans that nobody's ever gotten before, standing x-rays, bending x-rays. These are, everybody goes straight to an MRI. MRI can only tell you one thing. It doesn't assess the patient, the person in their functional state, which is upright, standing, bending. So I want all those pictures and I want them side by side and I want to measure them all with numbers. And very often I will go through that, to the extent that the patient is interested with the patient. Very often I'll get a CAT scan that has all the answers. Like a 2-minute CAT scan sometimes tells you the answer that an MRI can't possibly, because it's a bone question. So one common diagnosis is malalignment, so spinal deformity. Another common diagnosis is a flat back, meaning that your spine and your pelvis are not aligned properly to each other. Another diagnosis is acute arthrosis, where people have had an attempted fusion, but the fusion fails. Now, people say, well, the hardware looks intact or the instrumentation looks intact. That's not actually how you diagnose a fusion. A fusion is diagnosed with a very close thin-cut CAT scan and very particular parameters. And there is microscopic movement there that we know happens if you didn't fuse, and that can cause return of symptoms. So there's a lot of diagnosis that it could be, but basically what I'm saying is it requires very close analysis, and there's a lot of new information and diagnostic techniques that we need to go down.
That's very interesting. So alignment is really something that's key. Just out of curiosity, and I know you're not an orthopedic surgeon, but when you have these surgeries that are treating one specific thing, I mean, is this what the issue becomes, that somehow or other the rest of the alignment of all of the parts that are connected are somehow not now in the place they were, and so that may be causing some of the pain or dysfunction?
Yeah. So very often I'll have a situation where patients will say, well, my back hurts, but and they say, oh, and also my hands are numb and weak, but they don't complain of neck pain. And you look at them and they actually have a neck issue with a very small minor surgery, same-day surgery type of fix. or kind of a 2-day stay, 3-day stay in the hospital surgery kind of fix. And they've been told that they need major spine reconstruction, lumbar spine, because their back hurts and the way their back is positioned. Very often, one of the things I often get is when patients come see me is a total spine X-ray to look at exactly what you're talking about, the alignment and interrelationship. There's many theories on how to analyze that, and there's many techniques. And I've actually studied those and published in those myself. And they're quite interesting, and I can talk passionately about the theory of these things, but we don't need to go down that road right now. But
it's very interesting that you're taking sort of a holistic, look at the whole thing, and not just the one little piece that may be what is assuming that everyone is assuming is the cause of the pain.
You have
so
to.
I find that very interesting. I kind of want to change channels for a second and just ask you, if you were the patient sitting in front of you, what qualities would a patient, or should a patient, look for in a neurosurgeon?
So the qualities you should look for in a neurosurgeon is, number one, attention to detail. You want a neurosurgeon who's going to pay attention to details, right? When you're throwing pieces of information at them, they shouldn't be telling you the answer before they've collected before they've gotten all the information from you. They should be inquiring, and they should ask very relevant questions. It's difficult to know what these relevant questions are sometimes for someone who's not a professional, but obviously you can intuitively sense interest in these things. You want someone who's treating you, not the X-ray, right? If a surgeon says, I want to see your imaging first, and then tells you that they don't want to see you because you're normal, or that they already know what surgery you need based on a picture, an MRI, or, get another opinion, right? You want someone who's going to be treating your symptoms. I've had MRIs where very clearly there was XYZ problem, and I was expecting the patient to look a certain way. The patient had some other problem completely, and both of those issues were in the neck, and we actually did a much smaller procedure to address their real problem that was bothering them, and not just to make the MRI look better. That's number two. Number three, someone that takes time with you. Number four, someone that allows you multiple visits. Now, the second visit can be over the phone, but I don't expect any patient to not get frazzled. Everyone gets frazzled when they're in front of the doctor, and so everyone always has other questions. Especially for the bigger surgeries, you should always have a second visit. It could be a phone call, but at least have a chance to do it more than once.
So you were referencing the first visit, which you take quite a bit of time with the patient. Can you kind of walk us through what happens at that first visit?
So usually the first visit is I like to talk to patients over the phone. And the main reason why is most people are, in my opinion, understudied. So they'll say, I have this problem, this doctor told me I need this surgery. And I'll say, okay, show me, and my office will help you upload all your imaging. We have a very streamlined information technology services as part of our practice. We'll take a look at your x-rays, and we're going to say, you're missing an x-ray, you're missing an MRI, you're complaining of balance issues and you only have a lumbar. Balance issues are usually neck or mid-back. We need a new MRI. So what I don't want is for you to come in and I send you for a million other scans when I know you are going to need those scans just by hearing your story over the phone. So the first thing I try to do is talk to you over the phone. Once you get all your proper imaging, you come in, we'll sit down, we'll really quickly have you recapitulate everything just to your heart's content. Just tell me again what your history is. We'll probably ask some more questions. We'll probably find out some new details. Then I'll do a thorough physical exam. People feel like it's a head-to-toe exam. I'm not checking your lungs, though it sometimes might feel like it. I really am looking at your neurological and orthopedic function. And the key things we're trying to figure out is this a spinal cord issue? Is this a nerve root issue? Is this a nerve issue? Is this a shoulder issue? Maybe if it's a shoulder issue, you don't need me at all, right? But shoulder pain more than half the time is actually not in the shoulder, it's off the neck. And so we would then do a thorough exam. Then we sit down and I then pull up your imaging and we go through your imaging. And then finally we tie it all together. We say, this is what your history findings are. This is what you told me is your complaint. This is what we find on physical exam. And this is what it correlates to on imaging. You need to tie those three things together. And then we talk about options.
So let's talk about the options. Most people think about back surgery with quite a bit of fear because that sounds terrible, doesn't it? Oh, I'm going to have surgery on my back. But there are many different kinds of surgeries that you perform. I think discectomy, laminectomies, fusions, artificial discs, knifeless surgery. I mean, there's a lot of stuff you can go and search online, and I'm sure a lot of people who have these pressing issues do that and scare themselves even more. So can you kind of walk through, the kinds of techniques that you use, the different kind of surgeries you perform, and the way you approach those?
Sure. So you always, in my opinion, you always want to do the minimum surgery that will give you the maximal effect. Sometimes you have a doubt. Will the small surgery work or not? In those cases, if there's a reasonable chance it will work, I will often recommend doing the small surgery, knowing that, look, there's a slightly bigger surgery that might help you, but we're gonna keep that in our back pocket for now, right? If there's a 40 to 60% chance that a smaller surgery would work, I'm always going to recommend the small surgery. Some patients will say, no, I've already had 5 surgeries and it's always been people doing small surgeries. Would you please just fix everything that's wrong? And that's a longer conversation. I try not to jump to that, but some people request it. I would say to start with, a lot of surgeries are same day. A lot of surgeries almost none of my patients are braced except for neck fusions that go home the same day. These smaller neck fusions will often be braced, but usually almost always you're not wearing a brace. You have some limitations, but they have to do with wound healing. You don't want to re-injure things, so maybe no bending, no twisting, no lifting, but to make sure everybody understands, people say, what's my recovery time? And I often need to clarify things. Almost always you're up and walking immediately. I want all my patients up and walking immediately. If you're staying in the hospital, it's just to make sure you're comfortable before you go home. But a lot of things can be done outpatient. That's the one extreme. For those patients who've had multiple previous surgeries and we've spoken about it and they really need to be reconstructed, whether it's because their posture is terrible or because their previous instrumentation is loosening or broken, or their previous bones have not healed, or perhaps they were, positioned in a suboptimal position. Those are slightly larger procedures, and we'll talk about, but usually, again, even those procedures, when done, we discuss risks, we discuss benefits, but you're up and walking the same day or the day after, right? My key is mobilize you and get you back to normal as soon as possible. Most people are going to go home. Some people are going to go to rehab. I never anticipate these long hospital stays. I want people out of the hospital 3 to 5 days maximum, but usually 1 or 2 days, same day or 1 or 2 days. And I want you to go home and I want you to go about your daily life and slowly get back to things. At about 2 weeks to 4 weeks, you should be back to activities of daily living, and in about 2 months, you can probably go back to running and your usual level of activity. Now, if you weren't a major runner beforehand, I can't make you into a runner, but we'll try to get you back to what you were doing.
Very nice. So you mentioned sending people to PT, so physical therapy, and What happens though if someone comes back and they say, you know, I felt good for 2 weeks and now it's beginning to bother me, or something else is bothering me? What's the approach then? And I think that's our last question, as a matter of fact.
I think if someone says something else isn't bothering me, I would reevaluate, because people often have multiple issues. Not everyone who has a back issue needs a back surgery. Maybe they might also have a hip issue. Maybe they just need a knee scope. Maybe they just need an outpatient knee small little scope procedure. I would say number one, you reevaluate. Number two, you can always keep trying physical therapy. If there's a neurological deficit or loss of function, then to save the function of the nerve, that's a serious discussion. If it's just pain, that's really up to the patient, right? The patient has to guide me and tell me, how bad is my pain? Do I want it fixed? And what would it take to fix it? And then that's a discussion we have, right? If you're struggling and you're all day, you can't play with your grandkids, and you can't do the things you love doing, and there's a same-day procedure with a 2-week recovery that's going to treat that 95% of the time, that seems like most patients would say, yeah, why don't we do that? But if it's a much larger procedure for something that doesn't bother you very much, I would probably not even offer you. So it's very patient dependent.
Dr. Morr, that is it for our questions today. I wanted to thank you for taking time out of your busy day. As I said, you are sitting outside an OR, so I know you're about to go back in and do your thing. And we want to welcome you again to St. John's, although you've been with us for a little bit now, but we really do appreciate the time that you've taken to address these things with us today. So we do have some information that we'd like to share with our audience. The first slide is Dr. Morr's contact information across from St. John's Riverside Hospital. His phone number is 914-303-6548. And you can always reach us at info@riversidehealth.org if you need more information about Dr. Morr, including his contact information. Virtual urgent care, 914-964-4429. If something's going on and you have not had a chance to get to your doctor and you would like to address it, please use that phone number, 964-4429. And then finally, if you have questions about our webinar today, again, info@riversidehealth.org, or our physician referral if you need information about Dr. Morr or any of the doctors at St. John's. Please call us at 914-964-4DOC. That's 914-964-4362. And you can also email us at findadoc@riversidehealth.org. Thank you all. Have a great afternoon.
Have a good afternoon.